afternoon. I want to thank you for joining us for this presentation on OxyGeni, a CDO therapy that hopefully will be easier for you and your patients to get some wound healing issues resolved. My name is Anima Agarwal. I'm an orthopedic trauma surgeon down here in San Antonio, Texas. I work at UT Health, and I've had the pleasure of working with EO2 for the last year or so. We've also had several patients on this particular device, and I've been extremely pleased with the findings that we've had and the results that we've had for these patients that have had really problematic wounds that we really had no other options for besides trying to take them back to surgery. And we've been able to deal with these wounds in a nice fashion with this device without having to resort to more invasive procedures. I'm pleased to have both Kate Biasiali, Kate, and Mark Niederauer here. Kate is both the regional account manager and marketing manager at EO2. She has her Bachelor of Science in Biology as well as her diploma as an orthotic prosthetic technician. Her wound care industry experience spans over 15 years. Kate was in various roles for a leading negative pressure wound therapy company in medical education, where she leveraged her certificate in adult education and pioneered the organization's global medical education department. Kate has also worked in the biologic space as a clinical affairs manager before coming to EO2 over 2 years ago. Mark is the Chief Technology and Operating Officer for EO2. He has his PhD in biochemical engineering from Iowa State. He is a Fulbright Scholar and an AIMBE Fellow with more than 25 years experience in R&D, manufacturing and commercialization of pharmaceuticals and medical devices for tissue repair at companies such as Bayer, OBI, and Smith & Nephew. He has numerous publications and patents and is a frequent presenter. He is active in the community, serving on the boards of multiple organizations in education and workforce development. So without further ado, we'll go ahead and have Dr. Niederauer begin the presentation. Mark?
Thank you, Dr. Agarwal. Good afternoon or morning, everybody, depending on where you're at. Today, what we're going to do is we're going to go through some objectives in the sequence shown here. We're going to learn a little bit about how CDO differs from what you typically know as topical oxygen, even though they're both applied topically, and hyperbaric oxygen. Then we'll go through the new features and benefits of the OxyGeni system, which replaces the TransQ-O2 system we've had for years. And then we're going to talk about the latest science. So not only stuff that's been published, but the stuff that's currently in press and ongoing. And we'll cover all of those. And throughout, you're going to see some testimonials from various users that have had experience with the system. So as we get ready to talk about or reveal our first testimonial, I want you to see here is an overview of the system that we're going to be talking about today. And Kate will actually go through more of that as I get to that point. So here's Dr. Anderson.
We've been very, very happy with the results that we've seen. It's turned out to be a therapy that patients like, and it has resulted in some very excellent outcomes.
So what we're trying to address with CDO therapy, and this is common to oxygen therapies, but especially with CDO, we're trying to address the problem of marginal hypoxia. So if you think about a wound that's an area that is ischemic or hypoxic, and you cover it with what's a standard moist wound therapy dressing, it occludes the oxygen from the outside of getting in. And why is this important? Well, it's because there's a lot of effects of oxygen in wound healing. You can see a few listed here that if you take the oxygen away, you actually will impair the wound. It can actually force it into necrosis. Another thing that we've seen is that when we're doing studies and also out in the field, we've had multiple reports of pain. And if you think about it from a basic level, pain is very commonly associated with hypoxia. We all know that just from holding your breath. It gets painful pretty quickly. And you can imagine that in a wound environment, you get the same type of effect. So what is the importance of oxygen levels in wound healing? If you look at the normal cell processes, this is in dermis, about 3 to 4 millimeters depth, 45 to 55 millimeters partial pressure of oxygen. What typically is in that range for normal people. Now, as you start to get a compromised blood supply, you can see there as the oxygen levels start to decrease, certain things stop happening. Cell division, hydroxylation, and then go into anaerobic metabolism, which is just a matter of time before the cell dies at that point. However, conversely, if you increase the oxygen levels, you can actually increase quite a few processes. And we're not going to go through that today. If you want to learn more, there are some really good publications out there. And we do have a white paper on our website you can go to and download that references those publications that are out there. So let's do a comparison of oxygen therapies, starting with the history. How have technologies evolved over time? And we're going to compare it to another technology. So side by side, if you look at oxygen therapies that started off with hyperbaric oxygen, even before 1920, back in the 1800s. And when the phones came along, they were similar. They were large, bulky, and you were tethered to the system when you're using it. Now, as time went by, there were advances made. However, you're still, it's more technologically advanced, but you're still tethered to the system when you're using it. And as we go further along, you can see the devices became smaller, but still had the same restrictions as during your use. You were basically restricted in your activity to what you could do. Towards the end of last century, technologies advanced to the point where you could use them in more locations, but you were still basically tethered to the system. So it allowed for a wider location of use that it really didn't advance the whether or not you could do anything else while you're using the system. And now we come to today. The comparison is basically a cell phone. It's something that you can have with you. It's wearable. It's on all the time, and it's small. So it's very portable and wearable. Now, what effect does this have also in how we apply the therapy? So some of you may have seen this slide before, but for those of you who have not, this is an oxygen curve slide basically depicting penetration in 1 week. And the green dashed line is your normal tissue oxygen levels that we've discussed, and the ischemic red dashed line, that's just a theoretical level where you're hitting ischemia and you've got impaired wound healing. If you look at hyperbarics, you get a 90-minute dive a day. The oxygen in that tissue, it's been shown in dermis lasts approximately 3 hours, more or less depending on some publications, but it's about 3 hours. And then it goes back into a hypoxic state for the remaining 21 hours. Now, if you look at the intermittent topical oxygen, they follow the same treatment regimen as hyperbaric oxygen, and you get increased exposure. You don't get as much concentration in because you don't have the pressure effect from the hyperbaric. You do have some pressure because they pressurize the chamber, but not nearly as much. And then if you come to CDO therapy, what you see there is the curve goes up a little slower because we're a low flow oxygen company, and we supply low flow directly into a wound dressing. But once you get there, until you change that dressing, it stays there. And the effect is that you get over 20 times the amount of therapy with oxygen penetrating that wound than you do with either of the intermittent topical or intermittent hyperbaric oxygen therapy. So a little more closely specifications of the two systems. You see on the left, CDO is very wearable, small, battery powered. The topical actually requires a large oxygen concentrator that consumes a lot of power, generate heat, and it requires more space to be used and is noisy. But let's focus on the last two down at the bottom. Oxygen pressure at the wound. So one of the things that CDO therapy does is it does pressurize the wound slightly. However, since we're continuous on, we limit that with a pressure switch. We monitor the wound bed pressure to make sure we don't get capillary collapse. So you'll see it's less than 21 millimeters of mercury, and that's important because that can, we'll talk about that more later, but capillary collapse can block not only oxygen flow to the wound, but also nutrient flow. And then the oxygen purity is comparable, it's just the stuff coming out of the generator is humidified and it's nearly pure. So here's some of the features that the OxyGeni does have. I mentioned the pressurization. It has a pressure sensor that not only monitors the wound bed, it will warn the user if there's capillary collapse, but also warn the user if it stops flowing for any reason. It automatically adjusts the oxygen flow to account for environmental conditions, and it's variable flow. And that's important because we found in clinical experiences, you can actually modulate exudate levels using that by varying the flow rate. And it's a complete system. It includes oxygen dressings. Now, before we go on to talking about the OxyGeni, there is something I want to point out, because there is another oxygen therapy that's been out there. It's continuous, but it's disposable. And this one has, the reason we're bringing this up is because it's been cited as literature, and it's got negative results. It didn't show a difference in a driver study posed recently. And there's several reasons for that. One, this is the device. And if you look at the device, it's disposable. It's actually got a fuel cell that is a tape membrane. This membrane, well, actually the fuel cell inside that can dry out if it gets into dry environments, which all fuel cells can, including ours, but we warn about it, so we can actually monitor the flow. This device will not monitor or warn about it, and a lot of their study results were published in desert Southwest or the mountains where it's dry, or even in the winter where it's dry almost anywhere. Another one is that since this does not have a pressure sensor, it can actually cause capillary collapse, block nutrient flow, block blood flow, and actually cause ischemia of the wound because you're actually blocking everything from the body itself. And finally, this little fuel cell here, if you block the output port, my finger's on it right now, for not very long, or if you step on it with a wound, you cause a big back pressure going in, this will pop. You will not hear it. It's a very slight pop. However, what this device will do is you turn it on, you see the light flashing. This says it's working. However, I don't know how it can be working when I'm holding the fuel cell on my other hand. So there are some really serious setbacks with that device, and the results we don't think should be included in any kind of meta-analysis. So moving forward, I'm going to turn it over to Kate Biazioli, who's going to talk about the OxyGeni system. Kate?
Perfect. Thanks, Q. Hello, everyone. So we are extremely excited to be here today on the launch of our new OxyGeni system. And just as Q was mentioning, as technologies progress, they get smaller, they get more portable, and also they get more patient-centric. And so really what we're here today is to show you the intuitive, complete therapy system, which is the OxyGeni. So one of the things that always stays in our mind when we're looking at development of the products and our next steps is, why should clinicians want to work with us? And that's something that we always, as I said, keep close to mind. One of the resounding things that we hear back from clinicians that utilize us is that we are a complete therapy system. So it's the therapy unit itself and the dressing, and this will take you to full closure. You don't need 10 or 12 other dressings to be able to put underneath or do as adjuncts. So this will take you right there. But the beautiful thing is, this is just oxygen. It's pure oxygen. So if you want to utilize adjunctive dressings such as collagens, such as alginates, other foams, maybe silver dressings, you can absolutely utilize this underneath our system. So it's perfect. The other thing that we hear consistently in terms of feedback is the fact that this system is so easy to place. If you go onto our YouTube channel, you'll see it's either peel and stick or place and tape. These dressings are extremely straightforward to use. However, the results are jaw-dropping. In addition, as I mentioned, this is standalone to full closure therapy. So we're talking full epithelialization, no drainage, and Q later on in the session is going to go through the results of our randomized control trial, which really supports this. In addition, this is safe. When you compare and contrast this to hyperbaric oxygen or even often negative pressure wound therapy, this is extremely safe with few contraindications for the patient. And lastly, I don't want to let out too much out of the bag, but we do have some very compelling data coming out later on in the year with regards to the cost-effective nature of this therapy. And again, especially in comparison to negative pressure and HBO. So let's talk about some of the enhancements to our new dressings. So our OxySphere dressings. So here is our non-adhesive and here's our adhesive. It comes in two different sizes, both of our dressings. It comes in the 2x2 and the 4x5, either non-adhesive or adhesive forms. And we understand that clinicians are busy. Being in the industry for over 15 years, it's always on the go and trying to make sure that we're healing these wounds before they deteriorate, right? We want to get ahead of them. And so we made our easy dressings more foolproof in the sense that we put the blue bubbles on top of the dressing. So these are our oxygen bubbles, making sure that clinicians and even patients, a lot of patients are doing their own dressing changes. And really, when you look at dressing change times, you only need to change these dressings once a week or as necessary. So if the exudate levels are higher, you may need to change them more often. But generally, we're looking at once a week dressing changes. With regards to our non-adhesive dressings, you place these after your debridement and wound prep. Okay, you place these down and you can tape it down with adhesive films, tapes. You can place this and our adhesive dressings under compression, offloading boots. So really, these dressings are adaptable, they're extremely easy to use, and it's compatible with a lot of other therapies. Now, when we talk about our adhesive dressing, so we have made an advancement with regards to the adhesive durability on our new adhesive dressings. So it is a more durable adhesive. So we do recommend that you utilize this for patients only requiring 1 to 2 dressing changes per week due to the durability of that adhesive. And we do recommend that you put down a skin prep underneath where that hydrocolloid is going to be. It'll help with removal as well. So with this one, peel and stick, and away you go. Connect it to the therapy unit. So extremely easy to use. We don't have time to go into the full application, but if you'd like to hear it in a little bit more detail, you can log on to our YouTube channel and just search EO2 Concepts. Now comes the exciting part. So this is our old therapy unit. This is the old TransQO2, and we are replacing it and launching this, the new OxyGeni system. And you can see, first of all, that we've significantly reduced the weight and the size of the therapy unit. So with regards to the carrying case, it's really a lot more convenient for patients to be able to have this directly down proximal to the wound. And then you may even negate the use of the extension set, which is great. So extremely, extremely convenient and patient focused. The great thing about the charging on the OxyGeni system is that this is how we're charging it now. So this is a power pack that our engineers have developed to be able to charge the therapy unit itself. If you have the OxyGeni charged and this power pack charged, you could go approximately 48 hours without needing to do a charge, which is amazing. So the increased battery life is huge for patient compliance and ease of use. And the fact that you can charge this power pack, which we again are going to recommend as your main source of power to recharge this therapy unit. This can be charged with any micro USB charger. And it also comes with cell phone and adapter so you can charge your phone after your therapy's done, but still. So those are available for you as well. So patients don't need to be tethered to a wall or to a big device to be able to get their therapy, which is great.
Okay, well, thank you, Kate. With that, I'm going to talk about some publications, starting with ones that are already published, going to ones that have been submitted for publication, and then some that are still ongoing that were recently presented as well. So here, as we go through, these are some of the recent journals we've been published in. And as you see the results we're talking about, these are the kind of results you're going to see going through. So keep this in mind as we talk about the different studies. Some of the things we see is that, and we're not the only ones that have seen this with oxygen, it appears that the more you need oxygen, the better it works. So more chronic wounds, larger, weight bearing, etc. We've also seen pain relief, sometimes same day pain relief. So we'll go through some of the results as we go through the presentation. So the first one I want to talk about is our large diabetic foot ulcer study. This was actually designed in consultation with Center for Medicare and Medicaid. And what's unique about this is the first published study in oxygen wound therapy that has a true placebo arm. And you can see here the difference between the two groups was basically one group got oxygen, one didn't. Otherwise, the patients and the doctors, and even we as a sponsor, didn't know who was getting oxygen, who wasn't, until the blind was broken at the end. And that's one of the reasons that CMS called it the gold standard for how studies should be designed going forward, Here's another one. We incorporated a run-in period to screen out non-chronic wounds. So what we're interested in looking at, and CMS told us this, they wanted to make sure that if they're reimbursing for things, they wanted to be reimbursing for advanced therapies on chronic wounds, or wounds that wouldn't just deal with normal moist wound therapy healing. So in this, we designed a 2-week run-in period. We looked at both wound size using planometric analysis and wound closure rate. And of those that didn't make the criteria, they were dropped out of the study. And you can see that here in the consort out diagram. We screened nearly 400 patients, and by the time we got to intent to treat, most of those had dropped out, and almost 90% of those that dropped out were due to the non-chronicity of the wound that I mentioned. So that is highly unusual, and need to understand that that's why this looks a little different. And as we go forward, you can see the ones that did get into the intent to treat. We had a number of patients dropping out for adverse events on both arms, and we'll talk about that more in a little bit. You can see they're basically even, but there are different reasons that they dropped out. So if you look at the overview of the study, we were going for full wound closure with repitalization, no drainage, as Kate mentioned earlier. And the original design was to look at wound closure, but also effective baseline wound size, wound closure rate, and wound chronicity. So if you look at wound closure rate, we did something a little different. Rather than using a Kaplan-Meier analysis and just showing how the curves vary, we actually did an analysis of time to 50%, 75%, and 100% wound healing. So you can see overall in the group, and this includes patients that dropped out of the study that did not fully close for 50 and 75%. So out of 146 patients, we had a significantly faster time to healing with CDO. And for example, if you look at time to 50% wound healing, it was almost half and statistically significant. Now looking at the effective wound size, I want to explain this graph before I show the results below. We were asked to look at this and by CMS. And so what we did was we broke them into quartiles, analyzed the smallest 25%, et cetera, all the way up to the largest. And the number of patients in each group, each arm, were equal in each of those quartiles. And so what you can see here is on the left side, it says relative performance. 200% means twice as many wounds closed in that median size of that group. And the median size is shown. And what you see as the wounds get larger, the relative performance increases, which was a somewhat unexpected result. If you think about it, it's a 12-week time frame, and larger wounds typically would take longer to close. What we found is in the CDO arm, the results went down slightly as wounds got larger, but they decreased dramatically in the moist wound therapy alone arm. Similarly for wound chronicity, we looked at how fast wounds closed during the screening period, and that's the bullet all the way to the left. The 30-50, that means 30% in 1 week, or either 1 week screening period, or 50% overall. If you go to the far right, that's an accepted definition of chronic wounds. This is published by Laver et al. They did 60% in 4 weeks, and they showed that wounds that don't close at least that fast most likely will never close without the use of advanced therapies such as CDO therapy. So you can see as you go from left to right, it becomes more closed, more chronic. And what you see is that the relative effectiveness, again, increased dramatically as the wounds became more chronic. And what's really interesting is even though the numbers went down, the number of patients in each arm, because you're screening out the less chronic ones, the statistical significance actually increased, got better. Another one CMS asked to look at was weight bearing. So we looked at the plantar wounds. They're approximately equal in both arms. At the start, if you look at wound closure, the second table, what's interesting, in the active group, there was almost no difference between the two arms, whether it was weight bearing or not, the same percentage closed. However, if you look at placebo, moist wound therapy alone, hardly any closed in the weight bearing arm. The majority were in the non-weight bearing. And so what that resulted in is that you have a statistically significant benefit of CDO in weight bearing wounds of a little over 4.5 times as many wounds closing. And if we look at adverse events, the first column there shows overall adverse events. The second row shows those related to the study wound. So for example, one of the patients was leaving a facility on his motorbike and got into a motorbike accident. So that's clearly not related to study wound, it's just an adverse event. So related study wound, you can see it was almost half with CDO. Even more interesting, the severe ones that required hospitalization, these were all hospitalization due to trying to control the infection. You had a 75% reduction with CDO over placebo in this group. And lastly, there were no instances of gangrene in the active arm versus 2 in the placebo. And that's important because other research have shown the same effect, that oxygen can reduce the incidence of gangrene. And now in the same study, we have a second publication that was published in Wounds on the effect of debridement. And this graph shows it basically in the center is the results we just talked about. On the left there is one site that was actually one of our major enrollers that routinely did not debride very quickly. And that was all patients in both arms. And if you take that site out, you look at the far right, you can see there, on average, the sites debrided 98.4% of the visits. So very high debriders, very frequent. As you can imagine, not only in moisture wound therapy, this has been published by, again, Lavery et al. And others, that the effect of debridement in moisture wound therapy or any kind of wound care is significant because it greatly impacts wound healing. As you can see here, even, for example, with oxygen, if you don't debride, you can have stuff that's actually blocking oxygen getting in. And what we see is that the effect of debridement for that one site, they only debrided 41% of the time. And if you take that one site out, our overall performance increased to 2.5, almost 2.5-fold, 2.4x. And the statistical significance, again, even though the numbers went down, increased because of the delta.
Mark, may I make a comment right now?
Yes, please.
So, I mean, I think that's an extremely important point to let people know, is that the debridement really needs to happen. I think when you have a wound bed that's kind of stalled, even though the oxygen may be being supplied, sometimes it's not getting into the wound bed. And debriding that wound, getting that fibrinous exudate and that dead tissue out of there, even in between dressing changes, is important. And I know in the patients that we tried, we kind of would see that. We'd get some improvement. You'd still get a little bit of fibrinous exudate and stuff. And then trying to get a nice healthy bed of granulation tissue or bleeding tissue there really helps promote that wound healing, getting the oxygen there. Any other comments, Kate or Mark?
I think one of the great things about utilizing this in the home environment is that there's a wonderful product out there called DebraSoft. And for nurses at home that can't do sharp debridements, that is a wonderful tool to be able to utilize to be able to get that debridement there as well. So I completely agree, absolutely essential step. And there are different tools out there to be able to really get that biofilm out of there.
And I agree as well. Thank you for the comments, Dr. Agarwal, because this is something that we do routinely train on to make sure that people understand the importance of removing what would be, if you think about heating, insulation. Take the insulation away and the oxygen will transfer much quicker.
Absolutely great. Thanks.
Thank you. So in conclusion on this study, I'm not going to go through all this, but what is interesting is that CMS has cited this is the gold standards for how studies are designed going forward. We're starting to see this much more, and other studies are using the same type of standard to design theirs. And in overall, you can see here, you're getting anywhere between 200 to over 450% increase in wound healing, depending on what environment it's going into, and reduction of severe infections using CDO. And this backs up, this is one of the early quotes we got from Dr. Armstrong. This is when he actually saw the interim results early on in the study, is that it appears the more you need CDO therapy, the better it appears to work. And we do see that in other studies. And as I mentioned earlier, we're not the only company reporting that with our system.
Once you get a wound clean, this will close a wound way more effectively than most any other adjunct therapy. The first patient that I put on had 9 months of treatment. In 3 weeks, he was healed.
And that was Joanne Bowen, who is one of the co-authors of the pain study I'll talk about in a minute. Before I do that, though, I'm going to turn it back over to Kate, who's going to talk about a case study.
Perfect. Thanks, Q. So I happened to go into a clinic in the Austin area, and I approached the physician with this therapy, and he asked me, so what wounds do you think this works the best on? And obviously chronic wounds, we do a great job at. But I told him that recently I had been seeing a lot of post-surgical dehiscents really respond positively to this. And he said, I've got a wound for you. So he brought me in, and it was an 87-year-old diabetic male with COPD and venous issues. His third and fourth toes were amputated, and then he ended up getting a subsequent infection. He had been managing this for about 2 months, and you can see there pre-debridement. It was a pretty nasty wound. And when I walked in, the gentleman said to me, you know what, Kate, I want to dance again, and I'm going to lose my foot. And the physician was ready to amputate. And I was given the opportunity, said, if this doesn't work, I'm going to amputate further. So this patient in particular, he was afraid that he was going to lose his foot and he wasn't going to be able to dance again. And he looked me square in the eye and said, can you help me? And I said, know what? I've seen worse. Let's give this a shot. And the doc was ready to amputate this poor patient. So we ended up placing CDO therapy, and there was an alginate used underneath the foam dressing itself. And so Q, if you'll advance to day 30, you can see this is a completely different wound. Not only was it able to close in from the margins, but the depth fill was amazing. And so the results on this was huge. By day 75, this patient was closed. And these are the types of results that I see consistently in the field. And it warms my heart, and I'm really proud to be able to offer this to a lot of patients that are in need and at risk.
Thank you, Kate.
Of course.
So with that, I'm going to go into the final published study before we get into some of the current ongoing results. This is a pilot pain study we did because we'd heard so much, including Dr. Armstrong. His first response was that he thought this might do better for pain relief than wound healing, because wound healing just takes longer to see, but pain relief he was seeing sometimes same day. So we decided to investigate this. And while you're reading the slide, I want to talk about the quote at the top, I've lost my fear. This is actually a favorite quote of Robin Carlson, who you'll hear, one of the co-authors you'll hear from here in a minute. It was a Spanish woman who didn't speak English. Her son translated for her. But as you can imagine, she'd been treating a wound for about 8 months and really not making much progress. It was a venous wound with arterial component, so very painful. And this woman had become fearful of just even seeing her. She knew the visit was coming, didn't like it. And Robin proceeded to convince her to use CDO therapy as part of this study. And at the first visit, 4 days later, this was the quote. She actually greeted Robin at the door. She was cheerful. And her quote was, I've lost my fear, because the pain went away the same day and never came back throughout her treatment. So that was an example of what we saw in the study. What we allowed the nurses to do, this is a pilot study, so we allowed them to try it on various wounds that they had to be painful. We requested they be more painful the better, at least 5 on a scale of 10. And you see here they gravitated towards venous vascular wounds. Those are typically, especially with an arterial component, very painful. And that's what you'll see the results on as the entire group, but you can see the majority were in that venous vascular range. So overall, what was interesting is we saw every single patient, so 20 patients, 23 wounds, because a couple came back because they requested to come back in the study for other wounds. Went to 0 except for 1 went down to 1. Basically, it was, irritant, but basically they all reported significant pain relief. And what was even more interesting is we probably did not capture pain relief quick enough, because we were capturing it per visit. And by the first visit, 39% overall were pain-free. Over half had at least a 75% reduction in pain. And almost all reported pain relief noticeable by that first visit, with several reporting pain relief the same day, and multiple reports of not using narcotic painkillers anymore.
Yeah,
also, go ahead.
Sorry, Mark, real quick. I mean, I think in our experience, that was probably one of the most profound changes for the patient, was the amount of pain relief they were getting just from having this device on their leg. And we're talking about, I have a lot of acute trauma patients that were having some wound problems, and we were having difficulty getting some of these wounds closed. Pain was a constant problem for them, which we obviously felt it was more associated to perhaps the injury they sustained more than anything else. But once we got the oxygen device on them, got their wounds to start closing up and getting better, the amount of pain relief they had was, it was a very pleasant surprise that we were not expecting whatsoever. So, just from our personal experience, the pain aspect was extremely dramatic. That was like the first thing patients said they noticed immediately after the first application. So I think it's, now that we're hearing about it and more patients are getting this device, that seems to be a very uniform finding for all of these patients. And with this narcotic issues that we're dealing with, this is a terrific finding for us, because we're not having to prescribe narcotics or even anti-inflammatories as much. They're getting a lot of pain relief just from the use of this device. So I think that's a great benefit.
Thank you, Dr. Agarwal. And we agree. Our original experience, we were not expecting pain relief, and it was actually coming from the field that we started getting multiple reports of that. So thank you. So overall in the study, we basically 83% experienced significant or full closure, the largest being 170 centimeters squared. So these are very large wounds. That person's base pain was 10 prior to CDO, no pain at the first follow-up, a fairly common theme throughout. What was interesting, though, when we analyzed the group that didn't generally close, they actually responded faster to pain relief. We're not sure why. It's a small sampling, but it was an interesting thing to see. And I'm going to turn it back over to Robin Carlson for a comment.
What's not to be happy about if your wound heals faster and if your wound is more pain-free?
And if you want to learn more, you can see a presentation. It's a free on-demand CNE webinar with Present e-learning systems. It's available, and it's presented by Dr. Lavery and Robin Carlson. They'll talk about the two respective studies that we just went over. You get a different perspective from them on them. So with that, I'm going to go to a study that's just been submitted for publication. This is another study. Now we're looking at more, why is oxygen working? So we have multiple studies ongoing to look at things like cytokines, wound perfusion, bacterial load, quality of life, pain relief, those types of things. And so this was a pilot study done with UT Southwestern with Dr. Lavery and his team. We're trying to look at primarily cytokine levels. We were interested in doing this. It's only a 3-week study, so we're not trying to look for full closure. We are monitoring wound closure at the same time, but we really want to look at cytokine levels, wound perfusion, bioburden, things like that. So at 3 weeks, we actually did see a fair amount of wound healing. Over half had at least a 50% wound reduction. But what was interesting is overall, whether the wounds were closing relatively rapidly or even slower, at 1 week, we saw significant increases in cytokines and growth factors. And you can see here, they range from almost 300% with PDGF to over 800% with TGF-beta, and affecting a broad array of things that are important in the inflammatory and healing stages of wound healing. And I'll show you a graph so you can see the actual full 3-week progress on the next slide. And what was also interesting is something we didn't expect. We were doing TCONs to see how oxygen would affect it, and also using other wound perfusion techniques. At week 1, we saw significant changes in TCON from the baseline, which hypothesizes is the reason it's happening is you're recreating the angiogenesis in the wound bed. It's supporting the surrounding area as well. We're getting increases in oxygen saturation because the TCONs are done peripheral to the wound, not in the wound bed. So overall cytokine results you can see here, V1 is the actual before CDO. So that's the baseline. V2 would be the first week, V3 second, V4 third. You see there at week 1, V2, dramatic, significant increases in most of the cytokines and growth factors we studied. And then they start tailing off as you would expect during normal wound healing. They're not going to remain elevated all the time. The next two studies I'm going to talk about very briefly. These are just interim results. There are studies that are ongoing currently at Baylor College of Medicine. Dr. Bijan Najafi is the lead scientist, and we're working with two different teams, one in wound care and one in surgery, looking at plastics. So the first one I'm talking about is scar reduction after anterior neck surgery. And what we're looking at here is trying to look at multiple things. So in both studies, we're trying to reduce recidivism or complications afterwards, also reduce scarring. So you can see in the slides a visible difference. Left is the control group, on the right is CDO, but also using a laser to look at scar length. And so this is a 4-week study following surgery. And it does have a control group, so control is standard of care, and then the CDO group, of course, is CDO with our dressings. You can see here the results. Incision length was reduced on average 40% more with CDO versus the control group. And again, this is an interim, but it was statistically significant. And they did wound length reduction, and they grouped it, you can see, by 5 percentiles going up. And if you look at more than 10%, there was almost 80% reduction, or 80% of the wounds had more than 10% scar reduction versus only 30% with the control group. And something a little harder to quantify, but they were seeing, and they put into the poster, is that they were actually getting better visualization of scars. They look more normal with CDO therapy.
Yeah, just a real quick comment, Mark. Because when I saw this first, I thought, well, isn't that just a function of how long you're making the incision, right? In terms of that shouldn't really reduce. But in relating it back to some of our patients that we placed these on, we did see kind of a softening of the tissues around the wound that had been indurated or woody, if you will, for months just from having these chronic wounds. And so there's clearly something going on, which you can see from the cytokines and everything else in terms of changing what growth factors are being really expressed to really soften the wound up. And so it's nice to see that this is translating into scar reduction, as well as softening of the soft tissues around there, making it less adherent to the bone, if you will, and just more pliable all around the wound bed itself. So I think that's a really added benefit of just from the oxygen therapy itself. I don't know if you've seen that in other wounds as well, Kate or Mark, but it seems to be a very nice benefit.
We have, and great comments. Thank you. It's good detail to add. The reason we're doing this pilot is because we've seen experience on the field where people are using this for various wounds, and we're getting a lot of feedback that it's reducing scarring, especially in the plastic surgery where people are using it. So we want to start investigating more, not only why, but seeing if we can quantify that. So this is something we're seeing across the board. Even in some of our, if you look at the chronic wounds, for example, diabetic foot ulcers, the scars look more normal. And we do have an animal study that's also published that shows higher collagen organization with CDO therapy versus motion therapy alone.
Great.
Thank you. And so the last study, again, is very brief. This is now closer to home for chronic wounds. Basically, now you're going to, you had surgical excisions, so amputations, foot amps. And what we're trying to do there, the primary goal of this one was really to stop necrosis of the wound or dehiscence of the wound post-surgery. And you can see there, again, it does have a standard of care control group. So they're doing what they normally would do, and then they're adding CDO therapy in. I should note that early on, when we first started trying to apply CDO, we had to change the protocol slightly. Again, it's a pilot, so it will be fully noted. But it was primarily to control the exudate, because we were actually seeing a lot of exudate coming with CDO, and we had to try to manage that so it didn't cause any wound issues. So what you're seeing here is the ones that we changed the protocol and removed those. So the numbers you see reflect the changes after the change in the protocol. We also looked at oxygen saturation, which I won't talk about too much today because I don't have time, and percent wound reduction. And this is, again, a 4-week study, so it's post-surgery. So what they found, again, this is interim results, the study's not done yet, is that it significantly affected not only wound healing, but tissue necrosis. In the CDO arm thus far, there have been no reports of necrosis in the ones that have received CDO versus a 43% failure rate in the control group. Their estimate going into this that they would have about a 35% failure rate, so it's right on par with where their experiences with this type of surgery. And the wound length reduction, again, using the same laser system, was 70% greater with CDO versus the control group. So some very interesting results. Again, they're preliminary. I don't know if you have any further comments there, Dr. Agarwal.
I think that's it's kind of interesting to see that you're not getting that tissue necrosis when you have the oxygen, which hopefully is preventing any type of tissue necrosis from happening. So this is what we've seen clinically in some of our wound problems we've had post-operatively, where we've had bad diabetics with amputations or bad traumatic wounds, and they've gone on to heal those wounds with the oxygen, and it's really avoided them to having to go back for another operative procedure, which especially in this COVID day and age is even more paramount, because we're, as you're aware, we're having to COVID test all our patients going to the operating room. And so if they don't need to go to the operating room and be potential asymptomatic COVID or whatever, and we can keep them out of the hospital, that's really helping overall our situation, on a much larger scale, considering what's going on in the world today. So, but no, the results have been very, very satisfying, and we've been very happy with the results we've had when we've used the device. So,
thank you. So I'm going to close my section with one more video. This is Dr. David Armstrong, who was the overall PI of the DFU study you saw.
When we first learned about CDO therapy, I was really skeptical. I thought to myself, this is just a bunch of baloney. In fact, we were wrong. The results of the randomized controlled trial very recently, I think, really showed that, and they were compelling. And I think our clinical results have showed the same thing. On the patient side, changing the dressing every day is a burden, and sometimes we don't give that much thought. What we have found is that this kind of therapy, which is a little more set it and forget it, has been really helpful for some of our patients. And the reduction in pain that we've seen in a lot of patients that do have painful wounds, and that was surprising to us, and we're still not entirely certain why that's happening, but it seems to be happening pretty consistently. It's been really hard to get this therapy for many of our patients right now because it's not covered by traditional insurances. It's remarkable that it's not, because this therapy now has undergone a fairly rigorous randomized controlled trial where the data were not only surprising, but compelling. And I think that if we're being data-driven, if we're being patient-driven, if we're being patient-centric, and if we are all about the patient, then I would really, really support this being covered.
Yeah, with that, I'm going to turn it over to Kate.
So, Dr. Armstrong brings up a good point. So currently, we are pending our CMS approval. However, we do have the opportunity to treat many veterans that are accessing their care either through the VA facilities or clinics, or accessing their Mission Care Act benefits through their community providers. So this is available for patients. So if we've piqued your interest with regards to certain wounds that may be on your caseload right now, we can talk about that. Give us a call. You can email us at info@eo2.com or call our 1-800 number, which is on the website. Now, in addition to the VA, we do have some very forward-thinking managed care organizations who are working with us, who understand that they're looking at the whole bucket with regards to the amount of money spent per patient care. And they are very interested in working with us and opening up dialogues for those patients that they just are unable to heal, so we can really get them to full closure. And if you don't fit into one of those two top buckets, we do have a few limited free trials, both across Canada and across the US as well. So please feel free to reach out to us if you have patients that are in need, so that we can see our availability and opportunity to be able to assist. Anything else to add with regards to the CMS approval, Q?
No, I think right now what we're in is we are moving forward with CMS. We do expect to be able to get approval. It's just a matter of time. The more people can do to either write to CMS or contact us to help support. And this, again, supports the entire oxygen industry. The faster we can get this into the hands of everybody, benefit more patients.
Absolutely.
With that, moving on to questions.
Great. Kate, Mark, thank you very much. That was great. We do have a couple questions. I think one of the questions I even had early on, which someone brought up today, is you have a variable flow oxygen device. So you can increase or decrease the amount of flow of oxygen to a wound. So why would you need to decrease or increase the oxygen? Don't you want to just ramp it up to the highest amount and just, blow the oxygen into that wound and be happy with that? So why would we need to regulate it?
Q, I'll let you take that one from a scientific point first.
Sure. So what we found, and again, this came out of the field from our nurse experience. The nurses were the ones that were, when we're applying this to patients, if you think about from, back to our How Oxygen Works document, again, that's more of a compilation of what's published by a lot of other authors out there. When you add oxygen, you look at some of the cytokines and stuff we showed earlier, things like DEGF are dramatically increased. And what we physically see is that the wound bed, typically in the first week, reddens quite a bit. And at the same time, within 1 to 3 days, we see exudate levels kick up dramatically. So much so that it can be very hard to control exudate levels, especially when you're talking about a large leg ulcer. And so nurses started modulating the oxygen flow because we talk about this scientifically, that if you reduce the oxygen, it should reduce the amount of reaction going on in the wound. And they found that we were able to modulate and control exudate so they could manage it, so they could decrease the amount of dressing changes for the first week or two until that started settling down. And as you saw earlier on the cytokines, they do settle down for a while, and then they increased it again. So great question. That it turns out to be, we originally designed it for accommodating different wound sizes. It turns out it's also a fantastic way to help modulate treatment of high exudating wounds.
I think as an offshoot, I think we're having to really modulate not only the flow of oxygen, but the number of dressing changes early on to get an idea of how much wound exudate is coming out of the wound and then change accordingly. I know it's been mentioned that it can be left on a week at a time, but in certain situations, you still have to monitor the exudate and the dressing and make sure that it gets changed accordingly. And it may need to be done every 1 to 2, 3 days early on, but then once that gets under control and you get a better idea of how much oxygen you can actually put into the wound, maybe you can modulate that to even go 3, 4, 5, or even 7 days. Is that what I hear?
Correct. Very much so. And to your point, you can see, the nice thing about the dressing is that once it starts saturating, you can see the strike through on the top, and you can start monitoring when that's becoming saturated and remove it before it becomes an issue.
Mm-hmm.
This hasn't been asked, but I know we had this question early on. So, the dressing itself is for lack of practical or lack of a better way of explaining it, it's a two-dimensional dressing. It's very flat, and so the little I'm blocking here, the little oxygen cord, the tubing. What if you have a wound that's a little deeper? Are you do you have any recommendations for people? Can they pull it off the dressing? Can they lay it in the wound, then put, I know what we've done. I just want to hear from you guys what your recommendations are for patients that have a little bit more complicated or more undulating wounds that have valleys and troughs, etc., to better deal with this.
Your turn, Kate.
Got it. So when we look at the dressing itself, you're absolutely right. So we've had a couple pilonidal cysts. We've had a couple really, really deep wounds where we needed to get a little creative with the dressings themselves. So what you can actually do is take out the oxygen cannula itself. And I'm not sure if you can see, but there's holes, different holes throughout the bottom so that the oxygen can come out multiple places. What we've done for some of these larger wounds and some of these deeper wounds is you can take this out and you can wrap it up with, let's say, another foam dressing, maybe impregnated with silver or other antimicrobials. And you can place this down into the wound, let's say the pilonidal cyst, and then place this over top just as the extra absorbent. So going back to the whole adaptability of this system, the fact that you can take this cannula out and even use, if you have a very large wound, you can use 2 different therapy units and place one of these into the wound and another one over top. So now you're getting 30 mils of oxygen per hour instead of just 15. So the therapy unit itself goes through 3 mils up to 15 mils. So yes, you can definitely get creative with these different dressings.
Great. We have a couple other questions. One, it's kind of off topic, they did acknowledge, but they were wondering if you know of any research that's been done with oxygen therapy and neuropathy, and it probably goes back to the pain relief that we've been seeing with this device. But do you know of anything that's been actually looking at neuropathy being treated with oxygen therapy that you know of? I personally have not heard of any direct studies about that, but
I'm not aware of any direct studies. We've heard reports in the field. There is such a thing as neuropathic pain and getting relief from that too, but we've not directly studied it. I'm not aware of any others, but we have seen it in the field.
Good. Another question that came up, has this treatment been investigated for joint, ligament, tendon healing? Clearly it has some degree of deep penetration through intact tissues.
No, we've not gotten that far. If you go back to Kate's point, we're going to deeper wounds. A lot of wounds we do treat have open bone and ligament or tendons that are visible. And so we've treated those. We've not done any type of treatment where we're trying to do a deeper penetration and treat sublying tissues that are intact.
Great. Folks, if there's any other questions, we have a few more minutes left. Okay, what's the experience been from all the people that have been actually doing the dressing changes? Have you had most patients doing this themselves? Nurses been doing this? A little mixture of both? Have they had any complaints?
So with my 2.5 years of experience in the field, most patients are able to do their own dressing changes. It's very straightforward to do. However, they're, especially now, doing telehealth visits at least once a week to make sure that they're staying in touch with their provider. With that being said, nurses will be able to come in with home health as well to easily pick up the dressing and be able to do that. So I really find that it's a 50-50 within my practice. Hugh, did you want to talk about the RCT?
Sure. And going back to the first study we talked about, the 146 patients we had enrolled, we only had one patient that required home health to come in and help change dressings. That person did not have a significant other. The rest, we trained the patient themselves, but primarily somebody else was in the household to change the dressings. So between weekly visits, any dressing changes were actually done at home without any nursing support. And so those results reflect that.
Yeah, and I think that's a great point, and that's why I bring it up, is because, you know, a lot of our patients have wounds that they're not comfortable dealing with, or the type of wound treatment they feel much better with a nurse doing it, which that in itself adds a significant amount of cost and burden to the system. And so, you know, one thing at least that we found in our patients where they were very comfortable with the dressing changes themselves. They didn't need nursing support. Not that that's a bad thing, but you know, there is cost associated with that. And so when you're looking at overall costs of whatever type of medical treatment we provide, you have direct costs, you have indirect costs, and if the lower things you can, or the things you can decrease, especially the indirect costs such as home health care, etc., makes these much more cost efficient. So I think that's one nice thing with your device, is that it's very self-sufficient for the patient to deal with. I think your new charging apparatus is excellent. Obviously, when we trialed this, whatever it was, a year or so ago, we didn't have that aspect, but it still worked great. So it definitely have some great advantages that have been coming down the pipeline. So I'm very pleased to see this. Talking about cost, someone just asked how much is the unit, and obviously that's going to vary based on contracts and things like that, but I'll let you address that.
Yeah, you're absolutely right. So we do have a few different price points. If you're interested in learning more, please feel free to reach out to us and we'll find out the pricing for your specific FSS contract or area.
And what's the best way for people to get a hold of you guys again?
You can email us at info@EO2.com or give us a call on our 1-800 number. We've got all of our names and numbers listed on our website, unless you know it off by heart, Q.
No, EO2.com is my favorite response.
Well, great. I think that's been a great overview of this wonderful device. I've been interested in oxygen therapy a long time. I know we had talked about some previous oxygen dressings that had been out. We saw some great results with that, but I think this is really taking it to the next generation in terms of having a device that can monitor the output, monitor the whole system altogether, which I think is important for a lot of these devices to be able to do. As you pointed out with the other competitor device, it did not have a lot of feedback to it. So you don't know what it's actually doing or not doing. And so that's when you get into trouble on the patient, when you can't really monitor the wound in an appropriate way and you think something's working, and the next thing you know, the wound has gone south. And so I think having the capabilities that your device does have in terms of monitoring the outflow and making sure it's functioning properly is a very important step for making sure that these patients are getting what they are supposed to be getting, as opposed to just a blinking light that says everything's working fine, when in reality it's probably not. So, so great presentation, guys. Thanks again. I don't really have any other questions that are pending. Any other last minute comments?
No, I just want to thank you and all the listeners for your time. Dr. Animich, thank you for your support and your comments. And we look forward to hearing from everybody.
Thanks everyone for joining us, and hope this has been informational for everyone. Have a great afternoon.